Here is a number that stopped me the first time I looked at the data. Across multiple large population studies, individuals with certain blood types carry up to 3 times the stroke risk of their counterparts with a different type after 60. Same blood pressure, same cholesterol, same medications. The one variable that changes everything is a fact that has been sitting in their medical record since the day they were born, and that almost no physician has ever used as a cardiovascular risk variable in a routine appointment. My name is Dr. Elena Russo. I am an internal medicine physician, and I have been practicing in New Jersey for over 25 years. I started this channel because I kept sitting across from patients who had been given incomplete information, not because their doctors were careless, but because the system was never built to have this particular conversation. Today, we are having it. Before we go further, I want to ask you something directly. Do you know your blood type? Type it in the comments right now. And if you do not know it offhand, that fact itself tells me something important about how this conversation has been going in your doctor's office. Because if you do not know your type, your physician almost certainly has not told you what it is doing to your blood vessels today. Your ABO blood type is not a compatibility label that sits dormant between medical emergencies. It is an active biological variable, operating continuously, every hour, inside the walls of your blood vessels. And the way it operates has everything to do with a protein that most patients have never heard of. That protein is called von Willebrand factor. I am going to come back to this term throughout this video, because once you understand what it does, everything we cover will lock into place. For now, the simple version. Von Willebrand factor is released by the walls of your blood vessels. It controls how quickly and aggressively your blood clots when a vessel is damaged or irritated. Blood type O tends to keep this protein at lower levels and clear it faster from the bloodstream. Blood types A, B, and AB tend to keep it elevated, in some individuals by 25 to 30% compared to type O. Think about 2 patients sitting in my waiting room. Same age, 67. Same blood pressure reading, same cholesterol panel, same body weight, same level of physical activity. One has blood type O, one has blood type A. They look identical on paper. They are not at equal risk. The difference between them is not a lifestyle choice. It is not something either of them did or failed to do. It is written into the biology they were born with, and it is being expressed inside their arteries right now. Why does this matter, especially after 60? Because arterial walls stiffen with age. Because baseline clotting tendency rises naturally as the body gets older. When you add elevated von Willebrand factor to an already stiffening vascular system, you are not adding a small theoretical risk. You are adding a fuse to a building that is already dry. And after 60, that combination deserves a direct conversation, not a vague mention, a specific, named, documented clinical discussion. That is what this video is. Most of my patients with blood type A have never had a physician draw a direct line between that fact and their cardiovascular profile. They know their type for the emergency bracelet. They know it for blood donation. Some of them knew it before they knew their own cholesterol number. But not one of them had ever been told what their blood type is doing to their clotting system on an ordinary Tuesday afternoon between appointments. Blood type A is the most common non-O blood type in the United States, carried by roughly 28 to 30% of the population. It is also associated with the clearest and best documented elevated stroke risk of any single antigen blood type. Here is the mechanism, and I want you to follow this carefully, because this is the part your doctor has probably never explained. Blood type A antigens interfere with the normal clearance of von Willebrand factor from the bloodstream. Under ordinary circumstances, VWF is released, does its job, and is broken down and removed by a protein called ADAMS13. In type A individuals, that clearance process is slower. The drain is partially blocked. VWF accumulates at higher baseline concentrations, and when the vascular system encounters any triggering event, whether it is a blood pressure spike, a period of dehydration, or a night of atrial irritation, the clotting response that follows is faster and more aggressive than it would be in a type O individual facing exactly the same trigger. A research analysis published in the journal Neurology drawing on data from over 16,000 stroke cases across multiple genetic datasets, found that individuals with blood type A carried a significantly elevated risk of early onset ischemic stroke compared to type O, even after controlling for conventional cardiovascular risk factors. The finding was not marginal. It was consistent across multiple subgroups, and it pointed squarely at the clotting pathway, not at cholesterol, not at blood pressure, not at the variables we already track routinely, the element most physicians are not discussing with their patients. VWF levels can be measured. This is not an experimental or specialized test. It is a standard laboratory panel available at any major clinical laboratory, called VWF antigen level and VWF activity level. It quantifies how much of this protein is circulating in your blood right now and how effectively it is functioning. The reason it is almost never ordered in routine cardiology or primary care visits is not because it is technically difficult or expensive. It is because the clinical habit of connecting blood type to cardiovascular management simply has not been established at scale. Let me tell you about Margaret. 67 years old, retired schoolteacher, Morristown, New Jersey. She came in for her annual physical. Mild headaches, intermittent, easy to attribute to tension or screen time. Blood pressure entirely normal. No family history of stroke on the intake form. By every standard screening metric, Margaret was low risk. Her blood type, A positive, was listed in the chart. It had never been discussed as a cardiovascular variable in any of her prior appointments. I ordered a full clotting panel, including VWF antigen and activity levels. Her VWF antigen came back elevated above the 80th percentile for her age group. I referred her to neurology for an MRI. The scan showed a small lacunar infarct, a silent stroke, visible in the white matter of her brain. She had no idea it had happened. She came back to my office and sat across from me and said, "I didn't even feel it, Dr. Russo. What would have happened if I hadn't come in for that checkup?" I did not have a comfortable answer for her. I am telling you this now so that the question does not have to wait for the scan. If you have blood type A and you are over 60, here is the specific conversation I want you to initiate at your next appointment. Ask your physician for a VWF antigen level and a VWF activity level. Say those words exactly. Also ask whether your blood type has ever been factored into your cardiovascular risk assessment. If the answer is no, that is not an accusation. It is the beginning of a more complete picture. And if you also carry any of the following: atrial fibrillation, hypertension, a history of prolonged immobility, a prior TIA, that conversation becomes urgent rather than routine. But type A is not the highest risk profile in this video. There is a blood type that carries an even more compounded danger. And because fewer than 1 in 12 Americans has it, most physicians have simply never seen enough of these patients in a single practice to recognize the pattern. That is what we look at next. Blood type AB affects roughly 4% of the United States population. It is, by every measurable marker of clotting tendency and vascular inflammation that we currently have the tools to track, the most dangerous blood type for stroke risk after 60. And its rarity is a significant part of why it has stayed underreported. A general internist in a typical practice may see 20 or 30 AB-type patients across a full career. The pattern is simply harder to accumulate in a way that triggers clinical alarm. Here is what is happening biologically in an AB individual, and why it is different from, and worse than, what we just covered with type A. Blood type AB carries both A and B antigens simultaneously. The VWF dysregulation I described in type A patients is compounded in AB, not doubled arithmetically, but amplified by a second mechanism that operates independently. A large meta-analysis published in Arteriosclerosis, Thrombosis, and Vascular Biology found that AB-type individuals had the highest rates of venous thromboembolism across all blood groups and demonstrated elevated ischemic stroke risk that persisted after adjustment for traditional cardiovascular risk factors. But the study pointed to something beyond VWF: elevated levels of P-selectin, an adhesion molecule on the surface of platelets that makes them, and there is no gentler way to put this, sticky. P-selectin is the protein that causes platelets to grab onto a damaged vessel wall and start assembling the framework of a clot. In AB type individuals, platelet surfaces express higher concentrations of P-selectin at baseline, meaning the threshold for clot initiation is lower. A vessel wall irregularity that a type O platelet would pass without reacting, a type AB platelet is far more likely to cling to and begin building around. Now here is where von Willebrand factor becomes the piece that ties this together. In AB individuals, VWF is not simply elevated in concentration. It appears to be more resistant to the normal, age-related regulatory signals the body uses to modulate clotting speed. By age 65, an AB-type patient can be carrying VWF levels that a cardiologist reviewing a type O patient's labs would treat as a finding requiring active intervention. In the AB patient, those levels are not produced by a disease. They are produced by the patient's own biology, running at full capacity every day without any acute trigger. If type A has a partially blocked drain, type AB has a drain that is blocked and a faucet that will not close. I want to tell you about Robert. 71 years old, retired electrician, Princeton, New Jersey. AB positive, no history of heart disease. He did not smoke, had not smoked in 20 years. He walked every morning, 7 days a week, had done it for 15 years. He came to me after a TIA, a transient ischemic attack, what most people call a warning stroke. His previous physician had attributed it to a one-time blood pressure spike during a stressful week and had adjusted his antihypertensive medication. Nothing further was ordered. I ran a complete clotting panel. His VWF antigen was in the top 8% for his age group. His P-selectin was elevated, and when I performed an extended cardiac monitoring study, we found mild atrial fibrillation that had never been formally diagnosed because it was intermittent and his standard 12-lead EKG had been clean every time. 3 compounding factors, all present at once, none of them connected in any prior appointment he had ever had. We placed him on appropriate anticoagulation, structured based on his specific clotting profile, not a reflex aspirin recommendation. He came back 6 months later and sat across from me and said, "So this was never just the blood pressure?" I told him. The blood pressure was a factor, but it was never the whole story, and treating the blood pressure alone was never going to be enough. He looked at me for a long moment. Then he said, "Why didn't anyone say that?" If you have blood type AB and you are over 60, the conversation you need to have with your physician is specific. Ask for VWF antigen and activity levels. Ask for P-selectin measurement. Ask whether targeted antiplatelet or anticoagulant therapy is appropriate for your clotting profile specifically, not as a category, but based on your actual laboratory findings. This is not a fringe request. It is a precise and reasonable clinical question, and it will not be asked on your behalf unless you ask it yourself. If what you have heard so far has never come up in your medical appointments, I want you to type "never told" in the comments below. Because what I hear from patients and from people watching these videos tells me that this gap is not rare. It is the default. Now, before anyone with type O or type B closes this video assuming they are safe, I need to tell you something specific about what the protection that type O provides and what it absolutely does not. Type O's protective effect is real, and I am not going to soften that. Lower VWF concentrations, faster clearance, lower baseline platelet activation. These are well-documented advantages that show up consistently in population-level stroke data. If you have type O blood, your starting point on the clotting risk spectrum is genuinely more favorable than that of your type A or type AB counterparts. That is a fact worth knowing. But protective does not mean immune, and there are specific conditions that can erase that advantage entirely, some of which type O individuals are uniquely vulnerable to. Let me address type B briefly, because it tends to be overlooked in these discussions. Type B carries a moderate VWF elevation, lower than type A and substantially lower than AB, but it carries a distinct and underreported risk profile that involves a different pathway entirely. Some population-level data suggests that B-type individuals show higher rates of hemorrhagic stroke, a bleeding stroke rather than a clotting stroke, driven by mechanisms involving platelet activation patterns and endothelial fragility that differ from the classical VWF clotting cascade. The danger for type B is real. The mechanism is simply different, and it is almost never discussed in the context of blood type-informed cardiovascular care. Now for type O, here is the specific danger that almost no one is monitoring. Type O individuals carry significantly higher susceptibility to Helicobacter pylori infection, the bacterial strain responsible for peptic ulcers. This is a well-established genetic association. What it means in practice, particularly after 60. A meaningful proportion of type O patients who develop chronic gastric discomfort end up on long-term NSAID therapy, ibuprofen, naproxen, or similar medications for pain management. Chronic NSAID use in older adults damages the vascular endothelium. It increases hemorrhagic risk by compromising the vessel wall's structural integrity. The blood type that carries the greatest natural protection against clotting stroke can be pushed by a very ordinary medication that feels completely unrelated toward the category of bleeding stroke. And nobody in the clinical encounter is connecting those dots. 3 conditions can neutralize type O's baseline advantage entirely, regardless of the medication question: uncontrolled hypertension, atrial fibrillation, and chronic systemic inflammation. A type O patient who carries all 3 of those simultaneously is not biologically protected from stroke. The baseline advantage that the blood type provides is erased by the clinical context. Blood type sets the starting point. It does not determine the outcome. Blood type sets the baseline. But there are 5 things that can take any blood type's risk and multiply it significantly in the years ahead. They are all modifiable. And that is what we look at now. The first is atrial fibrillation. I have mentioned it twice already, and deliberately so, because it is the single most powerful multiplier of stroke risk in adults over 60, regardless of blood type. AFib independently multiplies clot formation risk by 3 to 5 times through a mechanism involving blood pooling in the left atrial appendage and losing its normal flow. When that already disrupted clotting environment combines with the elevated VWF baseline of a type A or type AB individual, both processes are working in the same direction simultaneously. The effect is compounded, not summed. If you have AFib and you do not know your blood type's VWF profile, you have half the picture. The second is dehydration during sleep. A study published in the American Journal of Clinical Nutrition demonstrated that even mild dehydration, defined as 1 to 2% of body weight in fluid loss, meaningfully increased blood viscosity and elevated VWF concentration. Most people who experience early morning strokes, the statistically highest risk window of the day, spent 7 or 8 hours without fluid in a position that already alters cardiovascular dynamics. For individuals with high VWF blood types, that overnight window is narrower and more dangerous than they have ever been told. A glass of water before bed and one immediately upon waking is not a minor lifestyle suggestion. For this population, it is a direct vascular intervention. The third applies specifically to women. Postmenopausal hormonal shifts, particularly estrogen decline, accelerate endothelial dysfunction, which means the inner lining of the blood vessels becomes less flexible, less responsive, and more prone to damage. For women with blood type A or AB, this can compound an already elevated VWF baseline at precisely the age when cardiovascular risk is rising fastest. Decisions about hormone replacement therapy for women in this group should include an explicit conversation about clotting factor risk, not just the general thromboembolism caution that often appears in the standard informed consent, but a specific discussion of how the patient's blood type interacts with the hormonal shift happening in her vascular system. The fourth is prolonged immobility. Long-haul flights, extended bed rest, post-surgical recovery. When movement is reduced for hours at a time, blood pools in the deep veins of the legs and pelvis. For high VWF blood types, this is the window when clots form at the highest rate. It is documented across surgical literature and aviation medicine research, and it is almost never discussed with patients before they book an international flight or undergo elective surgery. If you have blood type A or AB, and you are planning a flight longer than 5 hours or recovery period after any procedure, that conversation needs to happen before, not during the complication. The fifth is chronic NSAID use, which carries relevant risk across all blood types. Ibuprofen, naproxen, and similar medications taken regularly over months or years degrade vascular endothelial integrity. In clotting risk blood types, this creates a clinical paradox. The anti-inflammatory benefit is competing directly with a serious vascular liability that the prescribing physician may not have weighed against the patient's specific clotting profile. If you are over 60 and taking any NSAID regularly, even over the counter, that medication choice deserves a blood type-informed conversation. Here is what matters most about all 5 of these factors. Not one of them requires a physician to address. Every single item on this list is something you can act on before your next appointment. Dehydration is a glass of water. Immobility is a 10-minute walk every hour during a long flight. Awareness of the NSAID question is the first step toward raising it in the exam room. The information itself, heard clearly and completely, is the beginning of the intervention. Here is what you actually do with everything we have covered. I call this the Blood Type Stroke Prevention Protocol, and it is 5 specific requests for your next medical visit. Not suggestions, requests. The first, ask for your VWF level by name, not some clotting tests, and not a blood panel. Say these words specifically. I would like a von Willebrand factor antigen level and a VWF activity level. Write it down before you go in. Hand it to the nurse if you need to. This is a standard laboratory test, available at every major clinical laboratory. It is rarely ordered in the context of cardiovascular prevention because no one is asking for it. You are now going to ask. The second, confirm that your blood type is documented in your active medical chart, not just an old emergency record, but in the chart your current physician is working from today. Then ask whether your blood type has ever been factored into your cardiovascular risk assessment. If the answer is no, that is the answer you needed. It tells you the risk calculation guiding your care has been incomplete and where the conversation needs to go from here. The third, ask about an antiplatelet or anticoagulant strategy specific to your blood type and your VWF profile. This is not, should I take aspirin? Aspirin is a reflex recommendation. What you are asking for is a tailored decision based on your actual laboratory findings, your blood type, your clotting factor levels, and your full cardiovascular history. For high VWF blood types with atrial fibrillation, aspirin alone is almost certainly insufficient. Your physician needs your complete picture to make that determination. Your job is to make sure they have it. The fourth, address the modifiable multipliers before any pharmacological decision. Work through the 5 factors we just covered: hydration, mobility, NSAID review, hormonal context for women, fib monitoring. These are within your direct control, and they should be addressed regardless of what the laboratory panel shows. Blood type is fixed. Every other variable on this list is not. The fifth, if you have atrial fibrillation, ask your physician to calculate and document your CCHA-2DS to VASC score. This is a validated clinical tool that quantifies stroke risk in AFib patients, incorporating age, sex, heart failure history, hypertension, diabetes, prior stroke, and vascular disease. If you have AFib and a high VWF blood type, this score should be calculated, documented, and revisited annually. Most of my patients did not know it existed. Ask for it by name. Everything on this list comes back to the same biological reality. Your blood type is giving your blood vessels an instruction about how aggressively to form a clot. Von Willebrand factor is the chemical messenger delivering that instruction. You now know its name. Use it. If this video gave you something your doctor has never mentioned, share it with someone you care about. One share might be the most important thing you do today. I want to tell you about Dorothy. 74 years old, retired librarian, Hackensack, New Jersey. Blood type AB. Her daughter had to convince her to come in. Dorothy felt completely well. She had felt well for years. No symptoms she could name. No complaints she considered worth a visit. She came, she said, to make her daughter stop worrying. I ran a full panel. Her VWF antigen was elevated. Her P-selectin was elevated. And when I ordered extended cardiac rhythm monitoring, we found intermittent atrial fibrillation that had never been caught on any prior EKG, because it was brief, because it came and went, because her heart was behaving normally during every appointment she had ever had. 3 separate risk factors, each significant on its own, all 3 present simultaneously in a woman who felt completely fine. We placed Dorothy on appropriate anticoagulation, structured to her specific clotting profile, and on a monitoring protocol that included quarterly VWF assessments. 2 years later, a card arrived at my office. Dorothy was still driving, still doing her crossword puzzle every morning, still walking her dog along the same block she had walked for 30 years. The card ended with one sentence. You told me I was a ticking clock, and I didn't believe you. Now, I'm just a clock. Dorothy did not change her blood type. Nobody does. What she changed was what she knew, and what she walked into her doctor's office and asked for by name. That was the only difference between her outcome and a different one. Your blood type has been in your medical record for decades. In most cases, it has never once been used as a cardiovascular risk variable in routine care. That is not a conspiracy. It is an economic reality. There is no billing code that creates a financial incentive for that conversation to happen, which means the person who initiates it has to be you. Tonight, before you do anything else, look up your blood type. If you do not know it, find out. If you do know it, write it down and bring it to your next appointment. Not as a curiosity, as data. What we cover today lives inside you, in the biology you were born with, in a protein whose name you now know, and in 5 modifiable factors that are within your control starting today. But there is a risk that is just as specific, just as measurable, and just as consistently overlooked by both patients and physicians. And it shows up in something as ordinary as the way you move. Changes in gait after 60 are among the earliest and most reliable neurological signals of elevated stroke vulnerability that currently exist. Most people have never been told that how they walk and their risk of stroke are connected. The next video is where we go from here.